Good afternoon, everyone. My name is Dr. Dominic Akateba. I am with Ghana Medical Help. Thank you for joining us for this week's Community Service Agenda webinar on newborn jaundice. May is the yellow month, the month of newborn jaundice awareness. And Dr. Matilda Dono, pediatrician at the Gawes Municipal Hospital, has been gracious enough to accept to teach us about newborn jaundice, what the rural health worker should know. Just by way of information, immediately she starts, you realize I'll make it impossible for you to unmute yourself so that we don't inadvertently get disrupted. However, the chat box will be available if you want to put in a comment or question whilst the presentation is ongoing, and any pressing issues that you want to put in there, you could. But at the end of her presentation, we'll have some time for questions, comments, and contributions. So kindly join me in welcoming Dr. Matilda Dono. Dr. Matilda, your audience are waiting for you. Thank you so much.
Okay, thank you. So I hope I can be heard.
Yes, please, loud and clear.
Okay, all right. So like Dominic said, May is Yellow Month. It's Newborn Jaundice Awareness Month. And pediatricians all over the world, we are trying to raise awareness about newborn jaundice. When it comes to Ghana, Pediatric Society is usually our lead in helping us raise awareness all over Ghana. So this year, our theme is From Awareness to Action, promoting timely diagnosis and treatment for all jaundiced newborns across Ghana. My topic is what the rural health worker should know. We all work in the rural area. We know we don't have the sophistication and the specialists and the equipment, but there is still a lot more we can do when it comes to the newborn jaundice. So we are here to equip ourselves as to what we can do as rural health workers in this fight against jaundice. So my objective Hello, Dominic. Is my screen moving?
No, it's frozen.
Wow.
So if you can probably unshare and then share again and see if it works.
Okay. So you can see it now.
Yeah, it's coming up. Yeah, it's up now.
Okay. So it's moved.
Yes, it is.
Okay.
But not in a full slide share mode. Yep. Yep.
Okay.
Yeah, it moves. All right. Thank you.
All right. Okay. So I have only 3 objectives for this presentation. We are going to refresh our knowledge on your newborn jaundice. We are going to encourage rural health workers that we are still at the battlefront. The battle is still ours and the Lord's. And then we are going to empower the rural health worker on the ADAPT principle, which is to be able to anticipate newborn jaundice, detect newborn jaundice early, adequately counsel the caregiver appropriately, and then to do prompt referral. These 4 we can do, but then for most of us, a few of the rural health workers can also go ahead with treatment depending on the kind of jaundice. So this will be the outline of the presentation. We'll go through introduction, epidemiology, a little bit of physiology and bilirubin metabolism, causes, risk factors. I have a few case presentations that we'll look at. We'll do management, important considerations, and when to refer. That is where a bulk of us will have to pay our attention to. As for the treatment and the complications and things, they are done in bigger facilities. But we hope that we will all get a hang of what this presentation is about and get a take-home message to go home with. Okay, so by way of introduction, and I hope I can still be heard at this point. Hello. Okay, so by way of introduction, jaundice is the yellow coloration of the skin and the sclera, and that is caused by accumulation of bilirubin. The progression we all know is from head to toe, which we call cephalocaudal. For the incidence in term neonates, we are saying that 60% of term neonates will, by one way or the other, be jaundiced, and that represents 6 out of 10 babies. So if you are at the health facility and you are delivering 30 babies in a month, then you have to know that at least 18 of those babies should be yellow. And so if you are not seeing them, then it depends. Where are they going? Are you picking them up or you are not picking them up at all? Preterm deliveries usually doesn't occur in the rural setting, but we should also take notice that at least for every preterm baby, 8 out of 10 of them will be yellow, and we will get to know why they are. Why does this thing keep stopping? Okay, please, can you see my slide?
Yes.
I'm not sure why it keeps, but okay.
Yeah, it's up now.
So we'll go through a few definitions. We have early onset jaundice. That is jaundice occurring in the first week of life, the first 7 days. Then we have late onset jaundice. That is jaundice occurring after the first week of life. That's jaundice after the first 7 days to the 14 days. Prolonged jaundice is when you have jaundice persisting for more than 2 weeks, which is 14 days in a term unit, and then more than 21 days or 3 weeks in a preterm baby. We would have to understand that unconjugated bilirubin is the same as indirect bilirubin. Conjugated bilirubin is the same as direct bilirubin. And once we say that a baby has conjugated hyperbilirubinemia, which is usually calculated from the serum bilirubin or the liver function tests that have been done, it is when you have more than 20% of the total bilirubin being from direct bilirubin or conjugated bilirubin. So by way of epidemiology, incidence varies with ethnicity and geography. Most of the times in Ghana, in the northern and coastal areas have a higher incidence of jaundice. Geography, because when you are in mountainous areas, they tend to have polycythemia because of the chronic hypoxia, and they have higher incidences of jaundice. Jaundice is said to be the commonest condition you will come across when you are dealing with neonates, and 1 in 2 babies globally will develop jaundice. For the incidence, it's about 60% in Africa, 50% of babies born in Asia, and about 25% of babies born in America. And like I explained, the higher the altitude, the greater the incidence. And I have given the reason why. We already know from the introduction that about 60 to 80% of the newborns will go through jaundice, 60 for the term babies and then 80 for the preterm babies. And according to Ghana Health Service, approximately about 38% of all newborn babies will be jaundice in the first 72 hours. And that's why we actually need to anticipate and identify early. For regional disparity, Volta region recorded 1,200 cases in 2022. There's no data for 2023, 2024. And then in the same period, the Cape Coast Teaching Hospital recorded a prevalence of 32.9%. There have been a few studies done across Ghana, and a study at the teaching hospital that was assessing the knowledge of mothers on neonatal jaundice pegged it at 17.1% for mothers of mothers had knowledge of neonatal jaundice compared to about 7.1% of expectant mothers who had heard of jaundice. And with the same information, only 27.4% of them had received information from the healthcare facilities, which also showed that we probably are not talking a lot about it and are not counseling our patients enough. And 92.6%, which is actually a very huge figure, lacked knowledge about its causes, the causes of jaundice at all. In the facility where I work, we have an average admission rate of 600 per year. And most of the time, averagely, we have about 52% of our yearly admissions being jaundice. And the peak months are between May and July. And so it's not surprising that May is termed the yellow month. So in terms of physiology, we all know that bilirubin comes from a breakdown of hemoglobin, and the bilirubin is unconjugated. And the unconjugated bilirubin, which is not bound to albumin, is one that is neurotoxic. So it can cross the blood-brain barrier and cause all the problems that we would see going forward in this slide. But once the unconjugated bilirubin becomes bound to albumin, it is transported to the liver where conjugation goes on. So we have the unconjugated bilirubin being turned to conjugated bilirubin. That is further excreted through the bile ducts into the intestines, where you can have the conjugated bilirubin converted to stecobilinogen. A part of it will go through the portal system and go into the kidneys, where you can have it being excreted in urine. And then half of it goes into the large intestine, dependent on circumstances around normal floral guts and how well the baby is breastfeeding. These excess bilirubin will be excreted through the feces. So we have red cells going through hemoglobin, which will be converted to biliverdin bilirubin. Then the bilirubin is bound to albumin. That albumin is transported into the liver, and then through the effect of UDP glucuronal transferase is conjugated. And there are other conditions that we have to take note of these enzymes. So the bilirubin is converted to conjugated bilirubin. It will be excreted into, some will be excreted into urine. Conjugated bilirubin goes into the guts, just like I have explained. Depending on conditions in the gut, if for a reason the child has constipation, is not feeding well, you have infrequent stooling, the child is sick, the bilirubin, urobilinogen stays a longer time in the gut, and so can be converted back into bilirubin through the enterohepatic circulation. And we'll get to know some of the conditions that are responsible for this. So just like the diagram have said, you can derive bilirubin from hemoglobin, which is a bulk of it, myoglobin, which is heme-containing, and then some heme-containing enzymes. So like we said, bilirubin is bound to albumin for transport in the blood. When it reaches the liver, it enters the liver cell, is bound to ligand, and then transports, which will help it transport it to the liver for conjugation. And we have gone through this pathophysiology, so I hope we understand the pathophysiology. So usually with frequent feeding, there's early colonization of the guts, and these bacteria will reduce the bilirubin and the glucuronide that have been formed, and it will then turn it into stecobilinogen, which will be excreted in the stools. And this inhibits the enterohepatic circulation that I spoke about. So for any reason, if the baby is not feeding well, has constipation, or the gut is not colonized early, then you would have this enterohepatic circulation being enhanced, and that can also cause jaundice. So for the types of jaundice, there are basically two types. We have the conjugated and the unconjugated. Unconjugated, I said, is still the same as indirect, and conjugated is direct. So for the unconjugated, we have physiological jaundice and pathological jaundice, because some of the causes of unconjugated bilirubin can also be pathologic. But once you have conjugated bilirubin, which we defined as when you have more than 20% of the direct bilirubin being 20% of the total being direct, then it's most of the time pathologic. So physiological jaundice, most of the time it occurs after 24 hours. The bilirubin rise is not much. You have less than 5 milligrams per deciliter per day. It peaks around day 4 to 5. And for the preterm, that is in the term, and the preterm, it peaks around day 7. So it's actually will not be detected. So it will resolve on its own without treatment once you are able to identify the underlying cause. Most of the time, intensified breastfeeding, you wouldn't have it after 14 days. But pathological jaundice would appear within 24 hours of death. The increase of the bilirubin is very rapid. It has very high levels of bilirubin. And note that we said that unconjugated and conjugated bilirubin can all cause pathological jaundice. The jaundice will persist after the 24 hours, and most of the time you may find an underlying illness or a reason why this baby is jaundice. So most of the causes of the physiological jaundice, which is the unconjugated causes of physiological jaundice, are as a result of either reduced red blood cell survival or increased erythrocyte mass, as in the case of polycythemia, or there's poor hepatic intake or increased enterohepatic circulation, as I have explained. Then for the causes of the pathological jaundice, we said that they could be unconjugated or conjugated. We'll look at the causes very soon. So for the hemolytic causes of pathological jaundice, we have ABO incompatibility is the most common cause that we know, and that occurs when the mother is O positive and the baby has any other blood group apart from O. So once the mother comes to the antenatal, you identify that the mother's blood group is O positive. Because you don't even know the blood group of the husband, this baby has a 50-50 chance of becoming jaundiced. And so we can pick these risk factors at the antenatal. Resource incompatibility is when the mother has a negative blood group. And so this causes very rapid and most severe cause of hemolytic jaundice. So we need to take a critical look at it, especially when we have the O negative mothers, as to when we will let them go home. Even if we are letting them go home, then we are going to be very vigilant, bring them in early, educate the mother that that baby could be yellow. Then G6PD. So we know that the prevalence of G6PD in Ghana is about 15 to 25%. It's more prevalent in the northern and the coastal areas. That was why we identified this as a risk factor. So once the mother is G6PD positive and gives birth to a male child, because of his mode of inheritance, we know that the baby can be yellow. So that increases the baby's risk of getting jaundice. Then we have sepsis. So sepsis would let that baby not eat well. They would have fever, poor feeding. They would have reduced stooling. So this at the end of the day will increase your enterohepatic circulation, and then will let the baby become yellow. Kepha hematoma is just an accumulation of the blood underneath the skin. So this blood that has been accumulated will also eventually undergo hemolysis, and that will increase the serum bilirubin that you have and will lead or predispose this child to getting jaundice. So polycythemia on its own can cause jaundice. That is what explains the higher altitude parts. But we also know that infants of diabetic mothers also have polycythemia. And the explanation is the same because of the chronic hypoxia that they have. So at the end of the day, if we have a mother that has diabetes, gestational diabetes, we should anticipate that this baby may come out with polycythemia and the baby is at risk of getting jaundice. So for the non-hematological causes of the unconjugated pathological jaundice, most of the case, we know that conjugation occurs in the liver. So anything that has to do with liver function, liver enzyme, transport into the liver would, at the end of the day, lead to reduced function or reduce conjugation. And all these can increase the levels of bilirubin, which may at the time be unconjugated. So Klinger-Niger is actually an enzyme defect, and there are 3 types: type 1, type 2, type 3. The type 1 and type 3 is the Klinger-Niger syndrome. That's the severest form. And then the Gilbert syndrome is the type 2. So a lot of the times, these are genetic abnormalities that we may not commonly see unless we have done our genetic testing. So like I said, conjugated hyperbilirubinemia is always pathological. Sepsis is the most common risk factors, and in sepsis, the jaundice can be conjugated in 30% of the time or can be unconjugated in 70% of the time. So when it is affecting the function of the liver, then the bilirubin will be conjugated. We also have neonatal hepatitis A, B, and C, idiopathic neonatal hepatitis, which actually mimics biliary atresia. That is more common in the preterms. It's more in the males. They are sick. They are not thriving. They are not doing well. Then the torches infection. So these are congenital infections that we may identify in the mother. We know that we routinely don't screen for them, apart from the hepatitis B and the syphilis, but some private facilities these days are screening for rubella and toxoplasmosis. But for us in the rural sector, Ghana Health Service allows us to screen for hepatitis B and syphilis. And so we should bear in mind that if the mothers have these congenital infections, they can predispose this child to getting conjugated hyperbilirubinemia. Galactosemia is an enzyme defect that the baby cannot metabolize galactose. And so for some reason, they are not able to tolerate the feeds that we are given. So it comes back to infrequent feeding, infrequent stooling, increasing enterohepatic circulation. So Dubin-Johnson and Rota syndrome are transport-related syndromes. So the bilirubin will be bound to albumin and will be transported to the liver. And these transport channels, if there are defects in it, is what will give you these syndromes that we are talking about. So risk factors, and this is where I want us to avert our attention, because as rural health workers, we will be able to identify all the risk factors during the antenatal period and anticipate which babies are likely to be yellow. And so either decide to keep them at the facility and observe, or even if we are discharging them, to deploy community health nurses into the community to frequently visit them and identify these jaundice. So like we said, African descent, we have a 60% chance of our babies being jaundice. Geography, the rural versus the urban technicalities. We are in rural areas, so we understand that we may not have the sophistication, we don't have the labs, we don't have the skilled personnel, so we are going to rely on our history and physical examination. Those in the urban centers would have the availability of all these, and so their outcomes with neonatal jaundice may be better than those of us in the rural areas. Rural areas too also have very hard to reach communities, and so we need to identify the mothers that are at risk of having babies with jaundice so that we can comprehensively look at them, plan for their delivery, and what we will do when they are delivered. We have spoken about high versus low altitude. We've spoken about ethnicity. When if you are in the northern and the coastal areas, you are at a higher risk. Genetics and familial risk. So we talked about G6PD and the blood group, which will give you the ABO incompatibility and the resource incompatibility. We've spoken a lot about nutrition, that the more they feed, the more frequent stools they pass, and they inhibit enterohepatic circulation. Then birth weight, gestational age. So From the introduction, we said that preterm, 8 out of 10 babies will be yellow. Term, 6 out of 10 babies will be yellow. But preterm have their own challenges. They may have feeding difficulties. They may be plethoric, have polycythemia. So the preterm baby has a higher risk of getting jaundice than the term babies. We spoke about conditions during pregnancy, gestational diabetes, which will make the babies polycythemic and hence will increase their risk of getting jaundice. I just mentioned the congenital infections, then previous sibling with neonatal jaundice. And if we can, what management was done? And this is one of the history that we don't take at antenatal, because once we know that the mother have had other babies, maybe mother is O positive, you would want to find out, have your previous babies been jaundiced? And if they were, what mode of treatment did they have to undergo? Then Down syndrome. So Down syndrome is a whole topic on its own, but in relation to jaundice, there are some problems that the Down syndrome babies have. So they are hypotonic, and that hypotonia affects every part of the body. So they have slow motility, and so they have problems with feeding. They have hyperthyroidism, and the hyperthyroidism will increase their risk of getting jaundice. They will be constipated, and so they would also have increased enterohepatic circulation. So if you have a baby who has features of Down syndrome and you have delivered, then you should know that that baby would have a higher risk of getting jaundice because of some of these things that we have said. Jaundice babies, Down syndrome babies are also polycythemic. And most of the time, although all babies have liver immaturity, they have an increase in incidence of the liver immaturity. So all these factors are what predisposes them to getting severe jaundice. So this is the case study one that I have. We'll quickly go through the case studies. It's just a teaser for you to avert your minds to the risk factors and all the factors we have discussed. And then at the end of the presentation, we will attempt to see whether we can identify the risk factors. So we have a 4-day-old preterm neonate who was delivered via SVD, was discharged home on day 1. He presented with yellowing of the eyes at day 4. The midwife on duty noticed from the antenatal card that the mother is O positive and has G6PD partial defect. Upon interrogation by the midwife, the baby is not feeding well. The mom has been using camphor balls to perfume his call sheet. Her other male child was also managed for neonatal jaundice at the NICU for 3 days. So if you look at this case scenario, there are a whole lot of risk factors that probably if the midwife who had delivered this baby had paid attention to maybe the antenatal card or had examined the risk factors that the mother had, would have probably prevented this child from getting jaundice. So the question is, we'll attempt to discuss the management at the end, but we would also want to look at ways that we could have prevented this baby from getting jaundice. So case 2, a 5-day-old term neonate delivered via CS on account of big baby. The birth weight was 4.2. He presented on day 5 with yellowing of the eyes. The midwife on duty noticed from the antenatal card that the mother is O negative and has received the anti-D. The mother also developed gestational diabetes in pregnancy, but upon interrogation by the midwife, the baby also has a fever. So we would attempt to identify the risk factors in this case and what questions that we can ask when we are taking a history. Okay, so for the clinical presentation, Dominic, I hope I can still be heard.
Yes, please.
Yeah,
Loud and
okay.
clear.
All right. So for the clinical presentation, they usually will come with the yellowness of the eyes and of the body. They may have a fever, inability to suck, which are all the signs of sepsis, hyperglycemia. They may have seizures, respiratory distress, passage of pale stools, because we are usually not asking them what's the color of the stools are. So in the early detection that we spoke about, you would have to have a good history and examination. You should be able to determine the type of jaundice that you are dealing with, whether it's conjugated or unconjugated, exclude some of the medical and conditions we have talked about. And there are a few surgical conditions that can also be corrected. So what we have is a bilirubinometer. So it's more or less like a screening tool. It will be good for us to, in the rural health area, to have this meter because it's more of like a bedside tool that you can use to give you an idea whether this baby, how high the bilirubin is. It has its own challenges, but in the CHIPS compound and the health centers where you may not have access to serum bilirubin, this could give you a very good indicator as to how high your levels of jaundice may be. But we can still attempt to use the clinical examination to try and categorize whether our jaundice is mild, moderate, or severe. So when you are taking a history, you would want to look at the biodata. So apart from the name and where they stay, you would know that, one, a lot of the time they are hard to reach areas that we have in our community. So you need to note where the mother is coming from, how accessible your facility is. And if you are to take any decision, whether you want the mother to go home, the likelihood that the mother will come back, depending on where they are. Then you need to also take a history about the onset of the jaundice. Is it before 7 days? Is this after? That will tell you whether it's early or late. How the duration, how long the baby has been jaundiced for. Did the jaundice start at day 2, pointing towards physiological, or it was there on day 1, more pathological? The progression, maybe it was on the face, now you can see it on the abdomen, or it's the whole body. So all these ones will give you an idea. Then the frequency of the stool. So like we said with the pathophysiology of the enterohepatic circulation, if your baby is not passing stools, then you have an increased risk. The color, if the color is pigmented, yellow, yes, then it's more unconjugated. If you have pale stools, then you are looking at more conjugated or an obstruction. Then you need to take the feeding history. You all know that you are supposed to be feeding these babies 2 hourly. That is the mother's, there's the breast milk coming. When did the breast milk come? What was the birth weight? What is the weight you are seeing, the weight on the day you are seeing the baby? Has the baby lost significant weight? All these ones will give you an idea. Then we said about birth trauma, cephal hematoma, big babies, infants of diabetic mothers. So all these ones are predisposing factors. Then the history regarding the jaundice. So although they've come in, is the baby having seizures, respiratory distress, lethargy? That will tell you that this is severe jaundice with possible neurotoxicity. Then the drug history. In the setting where we work, there is a lot of herbal preparation, herbal use during pregnancy, herbal use to induce labor. And all these ones would have an effect on that infantile kidney. Camphor use in the case of G6PD. Then the mother's medical history. So we've talked about the blood group, the O positive mothers, the negative blood group mothers, and then the family history, whether they've had siblings with jaundice, any sibling that had died from jaundice, or what the form of therapy will be. Then when you are examining, you need to examine from head to toe. So we are looking for pallor, the severity and the type of jaundice. So unconjugated jaundice will always give you that yellowish tinge. Then the conjugated bilirubin will give you that greenish tinge. So if you are looking at the baby's eyes, is it yellow or is a greenish tinge? That would give you an indication, because you may not have a serum bilirubin. So is it yellowish or is it a greenish tinge? Then signs of dehydration, because if the baby is not feeding well, they would have lost weight. They look like old men and women. And then the fever, and in the extremes of cases, they may also be hypothermic. You may be able to palpate the liver and the spleen. Are there evidence of birth trauma? So the Kepha hematomas, they don't just disappear. The subgaleal bleeds, they will be there. So you'll be able to palpate whether they have a head swelling. Then the reflexes, the suck, the cry, the morals, how active the baby is. All these ones will give you an idea whether, oh, the baby is generally fine. It's probably physiological jaundice you are dealing with, or all reflexes are down. And so this is more likely to be severe jaundice. Then we have to look for the dysmorphic features as in the cases of Down syndrome. So the flat nasal bridge, the low set ears, all these ones will give you an indication whether you should be worried what the underlying cause of the jaundice will be. So we have the Kramer's rule. That is what has been depicted in this picture. So we have level 1 when the jaundice is just on the face and the facial creases. So when the baby cries, you see the yellowing on the face. That is grade 1. Then grade 2 is on the trunk. So once you blanch the skin, you have yellowing of the skin. That's grade 2. Once it moves to the thighs, the inguinal area, the thighs, then you are dealing with grade 3. If you have the jaundice on the hands and the legs, you are dealing with grade 4. And once the feet and the hands are involved, you have severe jaundice. And so for any reason, for us in the rural sector, we don't have a bilirubinometer, we don't have serum bilirubin to check. So we should be able to master this rule. And if we examine well, apart from all these risk factors and these examination findings we've spoken about, the physical examination of the baby itself and the extent of jaundice will let you know whether you are dealing with mild or moderate or severe. So 1 and 2 we'll consider as mild. 3, Kramer's rule 3 is a moderate jaundice. When you are 4 and 5, which I describe as the carrot babies, they come looking like carrots, then a severe jaundice. And the previous slide will show you the range of the bilirubin you are likely to be dealing with. This is in milligram per deciliter, but most of our labs record it in millimole per liter. So we may have to be multiplying these values that we have with 17.1 to convert it into the millimole per liter. So by the time the jaundice is at the pounds and the soles, you have more than 15 milligram per deciliter, which after multiplying, you will be in the ranges of 280s going to the 300s. So grade 1 has its corresponding bilirubin range. Then after you have done all this, your history taking and your physical examination, you should be able to make up your mind. If you have taken a good history, am I dealing with early onset, late onset, or prolonged jaundice? From the duration, that should tell you. We said prolonged jaundice is when the jaundice is more than 14 days in term babies and more than 21 days in preterm babies. Is it physiological or pathological? Because physiological, we said that will happen on day 2. It will peak around day 5 for the term babies, day 7 for the preterm. Pathological, day 1, they are yellow. Within 24 hours, they are yellow. So you should be able to make up your mind after the history and the examination. Am I dealing with physiological jaundice or pathological jaundice? Then the third one from your examination, even without an S, the serum bilirubin. If it's a yellowish tinge, then you are looking more of unconjugated hyperbilirubinemia. And if it's a greenish tinge with pale stools, then you are looking more of conjugated bilirubin. Then you should also be able to classify if you think it is because of feeding. Are we dealing with breastfeeding jaundice, or we are dealing with breast milk jaundice? So the next slide will give us the difference. So breastfeeding jaundice is an early onset jaundice. That means it's occurring very early within this first 7 days. Breast milk jaundice is a late onset jaundice. The breastfeeding jaundice it resolves quickly, is very short term. But if you have breast milk jaundice, that is jaundice that is persistent for a very long time, 4, 5 weeks, even up to the 12 weeks, then you are looking more of breast milk jaundice. The causes of breastfeeding jaundice, like we all know, is the poor intake of the breast milk. So you see that the milk didn't come in early. The baby, for some reason, is not breastfeeding well, and because of this inadequate intake, they will come in with signs of dehydration. But the cause of breast milk jaundice has to do with substances in the breast milk, which we spoke about during the pathophysiology, the beta-glucuronidase. So it inhibits the bilirubin and the conjugation of the bilirubin, and then increases enterohepatic circulation. So for breastfeeding jaundice, because of its inadequate intake, they will have signs of dehydration. The baby would have lost weight. But for breast milk jaundice, they are fine, they are healthy, they are gaining weight, they are just yellow. And then for the management, for breastfeeding jaundice, it improves with constant feeding. So you have to recheck your feeding technique. Are they latching well? Should the mother express and top up? Improve the feeding. And once you improve the feeding, the jaundice will get better. Breast milk jaundice, they are already doing well. So you only reassure them and then you continue breastfeeding. So as at our level, rural health workers, we need to make very important considerations and know when to refer. And that is when the P comes in, promptly referral. So your decisions to refer will depend on where you are, whether it's a CHIPS compound, it's a health center, it's a polyclinic, or it's a district hospital. How far are you away from the district hospital? You would have made up your mind what kind of jaundice you are dealing with. So what management would the baby need? Will I need to just encourage the mother to breastfeed, top up, or I will need to refer this baby because it's probably conjugated or the bilirubin levels are very high? And if the baby is jaundice, can the baby be managed safely in your facility? So if you have identified that it's severe jaundice, it's Cramer's rule 5 or 4, and you don't have a powerful photo machine at your end, and you have the improvised photo, the bulb one, or a photo machine, then that baby may not be safe at your end, although you may have the phototherapy. So you should be able to decide whether the baby can be safely managed there or not. And then you should promptly refer to, if the baby has higher risk, to a higher level facility, because maybe you probably don't have the labs to determine how high the levels are. You don't have the phototherapy equipment, or you don't have the skilled healthcare personnel. And even for those in urban areas, you have to determine the availability of surgical interventions, because if it's biliary atresia, you may need a surgical intervention. If you want to do an exchange blood transfusion and say the cord is off, you may need the surgeons to recannulate the cord for you to be able to do exchange transfusion. So all these ones are what determines whether you would keep or you will refer. Can you do exchange blood transfusion at your end? And even if you are in an urban area, there are still some of the babies that need to be seen by pediatric gastroenterologists, neurologists. So at what point would you refer? These are very important considerations that you need to give. So once the baby has arrived at a facility with investigations, these are what will be done. We can actually preempt what it will be during antenatal. So if the mother is blood group O positive, you could have called the father during the antenatal visit to check the father's blood group and then have an idea, because we have a lot of O positive. If both of them are O positive, then there's no risk. If the father has a different blood group, then you are looking at a 50-50% risk. And so you should be aware. However, once the baby is jaundiced, you can use the bilirubinometer as a screening tool. We have talked about that, but you need to take the serum bilirubin and find out whether you are dealing with conjugated or unconjugated hyperbilirubinemia. You need to do a full count, because most of the time the HBs of neonates we know are higher, but some who have polycythemia come with HBs of 19, 20, 21. And once you are seeing that, then you know that this baby still have a higher risk of getting jaundice. So you will still need to be extra care. The blood group of the baby, if you can do a Coombs test, better for you. You can do the G6PD status of the baby. Then for the investigations we do for the pathological or the prolonged jaundice, a lot of the time it's either conjugated or it's as a result of liver problems. So you want to know what the liver function are. Thyroid, we can also do a thyroid function test, which will also give you conjugated hyperbilirubinemia. We said that most of the time, 30% of the cases are sepsis. So you want to do a septic screen, blood culture, urine culture. If you can do a torch screen, that is also better. And most of the time at the rural end, which ends at most of the district hospitals, you want to do an ultrasound to rule out a biliary atresia. So the aims of treatment. So you only have two aims. You want to reduce the incidence of the severe hyperbilirubinemia as fast as possible and then prevent encephalopathy. And the modalities are breastfeeding, and breastfeeding alongside phototherapy and exchange blood transfusion. So breastfeeding is constant. You can do phototherapy to add on, exchange blood transfusion, because all these ones do not bar the baby from feeding. And we know that with increased stooling, that is what would increase the excretion of the jaundice. So it's always a combined therapy. The principles of phototherapy is just to convert these insoluble bilirubin to water-soluble forms using a higher radiance of light so that it can then be excreted into the urine or the stools. And that's how your baby, that's why your baby have to be breastfeeding, because the phototherapy will do the conversion, but when it is converted into water-soluble forms, it is the adequate breastfeeding that will increase the excretion for you through the urine and the stools. So indications for phototherapy. We have a phototherapy range. It's usually more than 15 milligrams per deciliter in the 10 babies. Or if you have done so you would have to multiply this by 17 to get it in the millimole per liter, which most of the labs report in. If you have a baby who you thought was doing well with maybe just breastfeeding, and you sent them home and they came back again in 24 hours, and the serum bilirubin has increased more than 5, which is mostly around 70 or 75 millimole per liter within 24 hours, then it's an indication to start phototherapy. There are very few contraindications, which is when the bilirubin is conjugated, once you put them under light, in 24 hours, they become bronze. Or there are diseases where some babies are hypersensitive to light, and those are the only contraindications to breast phototherapy. So the technique is to wash your hands. You place the baby naked in the incubator or a cradle. You fix their eye shades. You protect their gonads. In the case of the firefly, the machine should be at least 30 to 45 centimeters from the baby. So the distance between the baby and the light should be at most 45 centimeters. Then when you start phototherapy, you should still take them out every 2 hours to breastfeed and top up. You have to change their position once every, like as regular turning. Then you record their temperature, because for those who have phototherapy, it gives a very high range of temperature. So the baby can be hyperthermic. Then you need to monitor the bilirubin levels, which we typically do once in a day. You record their weights daily, because if they are doing well, they are feeding well, although there's frequent stooling, they would still increase in weight, and then you monitor their diapers, their urine frequency. So this is how a firefly looks like when it's not in use. And then this is a baby under firefly. So the eyes, there's an eye shield, they have a diaper. And these are the complications. So the complications of phototherapy, they can be dehydrated if you are not feeding them well. They could have fever as a result of the machine itself. We have the phototherapy rash, where the baby is fine, but undergoing therapy, they seem to have a generalized rash. then this is a complication that we don't acknowledge. But then during the time that they are under phototherapy, it upsets the bonding between the baby and the mother. And like I said, when the bilirubin is conjugated, there will be bronze baby. Then the late symptoms is the retinal damage. That's the reason why we cover their eyes, and the gonadal damage, why we cover their gonads. So exchange blood transfusion is at very high levels, which we don't expect. Those are the rural areas to be doing. At least if we are identifying the risk factors and doing what we have to do, we may be able to anticipate and detect early, probably cancel and intervene before we get to these treatment options. So when the bilirubin level is more than 20 milligram in a term baby, or about 15 milligram per deciliter in a preterm, or your bilirubin level is rising very rapidly, or the baby has clinical signs of connectors. So for the exchange blood transfusions, the cord is not off. You cannulate the umbilical cord. The idea is to take out all the blood and then replace the baby's blood with new blood. You are cannulating the cord. So at times there could be gut perforation, there's peritonitis. If the procedure is not sterile, transmission of infection, it's a sort of blood transfusion. So you can have all the problems with blood transfusion, and there can actually be cardiac arrest. And for the treatment of the unconjugated bilirubinemia, we said that you would have to identify the underlying cause. So biliary atresia surgery, sepsis antibiotics. If there are liver problems, you need to support them. So parental vitamin K, vitamin A, and D, and then hope that the jaundice will be better. So complications of severe neonatal jaundice, we have hearing impairment. So once we have hyperbilirubinemia in an exchange blood transfusion range, then it can cause cochlear damage. So you would want to do a hearing assessment for them at 6 weeks. We know that it causes developmental delay, where all their milestones are delayed, cerebral palsy. And for some of them, especially with those with chronic liver failure, their liver may just fail, and you may need supportive management until the baby probably expires. So this is how the carrot babies look like with connectors. It is bilirubin staining of the basal ganglia. The clinical diagnosis is bilirubin-induced neurotoxicity. So for the treatments, you would have to, after you have treated the hyperbilirubinemia, you need to counsel the parents on what they should be expecting: hearing impairment, developmental delay. Once these delays start setting in, you may need to refer them to physio. The hearing impairment may cause speech and language therapy, and they may need long-term follow-up with the gastroenterologist and the neurologist. So I hope I'm within time. Back to our case study 1. Dominic.
Yes, I can hear you.
Okay. All right. So back to our case study. We said we had a 4-day-old preterm neonate that was delivered via SVD and discharged home on day 1. Most of the time when our preterm babies are fine, we'll discharge them according to protocol. Then the baby presented on day 4 with yellowing of the eyes. The midwife on duty noticed from the antenatal card that the mother is O positive, has G6PD partial defect. The baby is not feeding well. The mother has been using camphor balls to perfume, and the other male child also had neonatal jaundice. So the red flags are what we had that have been highlighted in red. So the baby is a preterm. We said that 8 out of 10 of them will be yellow. So maybe if this midwife knew, then probably she would have sent a community health nurse with the baby, so that the community health, the public health nurse will check up on the baby on day 2 or day 3, bearing in mind that the baby can be yellow. And especially with this combined risk factors, the mother is O positive, the mother has G6PD, this is a male neonate, the baby is also not feeding well, mother is using camphor balls. So all this scenario makes us understand that we didn't do a good job at the antenatal, because once the mother was O positive combined with G6PD, if we counsel the mother well, she wouldn't be using camphor balls. And if we had gotten the history of the male child also having neonatal jaundice, a previous sibling having neonatal jaundice, then we shouldn't have actually allowed this preterm delivered to go home on day one. We probably would have retained them in the hospital or aggressively look for jaundice, let the mother establish the breastfeeding, maybe send them to a place where they can do a serum bilirubin. And so if we did a good job at the antenatal, then we could have probably prevented this baby from getting jaundice, because by the time they came, the baby was not feeding well. And who knows, that may be an early onset of neurotoxicity. And then for the case 2, we have a 10 baby who was delivered via CS on account of a big baby. He presented with yellowing of the eyes. The mother has blood group O negative. So we are looking at a resource incompatibility. We didn't do the blood group of the baby. So we don't know whether the baby is O negative or positive. And the mother has gestational diabetes. We said that they are at an increased risk of polycythemia. The baby may be jaundice. And now this baby has a fever complicated by sepsis. So if we probably knew, what we could have done was that we could have done the blood group of the baby when we delivered before sending them home. If the baby was the same blood group as the mother, then we are sure, and we will encourage the mother that breastfeed well, observe for jaundice. Your baby is at risk of jaundice. We wouldn't wait to see them on day 5. They should come on day 2 or day 3, or stick to even the Ghana Health Service protocols, day 3 review, day 7 review, before the 40-day review. And then we'll be able to catch all these mothers who have whose babies are yellow within the first few days. So in conclusion, jaundice is yellowing of the skin and the mucous membranes. We should be able to make up our mind whether it's physiological, early onset, late onset, whether it's pathological. Then the unconjugated bilirubin we know is very neurotoxic to the brain, and hence we need to intervene. And then we need prompt diagnosis and management to help prevent the severity. The modalities of treatment, apart from breastfeeding, is phototherapy and exchange blood transfusion. So my take-home message, jaundice is very common. We should identify the risk factors from the antenatal and educate the caregivers to look out for it. Once we know that breastfeeding plays a critical role, we should make sure that mothers are able to establish breastfeeding before they go home. We should encourage the day 2 to day 3 review for the babies that are delivered via SVD, so that we can take the opportunity to re-examine them again. If you have concern because of the risk factors, you can actually keep them in the hospital and monitor for the jaundice. And for facilities that can do serum bilirubin and mothers who have had cesarean section, we can actually aim to do a serum bilirubin for the babies before we discharge them. We should note that the complications are very rare and they are far more expensive than the prevention. So in all our doing, we should seek to do the right thing and identify the risk factors. So these are my references. I'm open to questions, contributions, comments. Dominic, over to you.
Yeah, excellent, Matilda. Thank you so much. Dr. Matilda,
Yes,
can you hear me?
I can.
Fantastic, great.
Okay.
Thanks for a legendary job done. This has been good, this has been comprehensive, and this has been educative. I've learned a lot. The last time I learned neonatal jaundice was about 10 years ago. So this has really, yeah. So participants, kindly electronically put up your hand if you have a question, a comment, a suggestion, or a contribution. And then I would ask you to unmute yourself to talk. Great. Lydia, thank you for putting up your hand. Please unmute yourself and go ahead with your contribution.
Thank you so much for the opportunity. And I must say it was a very good experience. Thank you so much, madam. But then my question is, I heard, or let's say we all know that May is a yellow month which is used to create awareness in the whole nation. But then I want to know what actually happens. I mean, what went on or what actually happens in May that makes it a yellow month? Is it because of high is it that we record high jaundice cases, or what is so special about it? Thank you so much.
Okay. So Dominic, how will you do it? I should answer it as they come, or we'll take a few questions and then we'll answer.
I think please answer it as they come. When we're done with this, we'll move to the next.
Okay, so it's yellow month. I actually said it in my presentation. A lot of our deliveries in Ghana happens around May, June, July, and even from my hospital, our peak incidences are in May, June, and July, and it's across board. Even for maternal mortality, we tend to record a lot of maternal mortality during these peak periods. So that's when we have a lot of deliveries per our data, and so obviously it will make sense that once the jaundice will most likely occur, we tend to have a lot of cases around that time. It starts from May. And so the idea is that once we are creating awareness and everybody is getting on board, we'll be able to sail through June, July, August safely, and hopefully won't record a lot of mortality. So that was the basis for picking May as the yellow month.
Fantastic. Thank you, Dr. Matilda. So next is Francis Pima. Please unmute yourself and go ahead.
All right. Thank you very much for your in-depth presentation. I'm speaking from Navrungu,
Wow.
War Memorial Hospital specifically.
Okay.
And there are two things that I want to talk about.
Okay.
You spoke about retinopathy.
Yes.
It is a concern. I was privileged to be among data collectors for Ghana Health Service a few years back on newborn care in Ghana. And while we were going around the NICUs, we realized that people were using different kind of material to protect the baby's eyes. So I want to suggest, can we come out with a standardized format or something, some material that we say that this is what Ghana is using to protect the baby's eyes during phototherapy, so that we'll prevent this retinopathy. And the second one is this bilirubinometer. Can we make them available, especially to district hospitals, so that we can easily monitor the bilirubin level of these babies? Because it's becoming challenging. Most of the facilities in our setting will rely on serum bilirubin. And there are instances where most of the facilities do not run this. You have to go to private facilities. Sometimes you go to the private facilities and the results they bring are so challenging to comprehend. So these are just the two things that I want to contribute to. But I enjoyed your presentation. Thank you.
Thank you. So basically, the standard material, you are supposed to use a dark cloth that will not let the light penetrate. But you know, as Ghanaians, we improvise a lot. So a lot of the time when we don't have the standard dark material, we tend to use, I've seen lots of things being used, like face mask, in fact, cotton, gauze, everything has been improvised. But then ideally, the ideal material should be dark enough that shouldn't allow the phototherapy radiance to go through. So it's supposed to be a dark material. We will probably look at it and channel it through Pediatric Society and see whether we can have something standardized across board. For the bilirubinometer, so bilirubinometer is quite expensive. As at the last time I checked, it stands at around between 15,000 and 20,000 per meter. But from experience, it has been quite durable. And so it's not a bad idea at all to have it at the rural areas, because it gives you an idea of what you should do. Should this baby go ahead? Although the clinical examination would help you a lot, but with the bilirubinometer, you can decide what you should do. So yes, it's a great suggestion. It is.
Great. Thank you so much.
Next is Mohammed Abdullahi. Please unmute yourself and go ahead.
All right. Thank you very much, Dr. Matoda, for your presentation. I really enjoyed it. Doc, there are some myths I have, so I want maybe if you can help me clear them.
Yes,
One
please.
One had to do with, I heard something like the Lion King, where the old method of exposing babies to the early morning sun seems to show some positive results about resolving neonatal jaundice. I want you to throw more light on it. Then secondly, the use of naphthalene bulbs. What correlation has it got to do with increasing the chances of babies getting jaundice? Thank you.
Okay. So, like you said, myths on jaundice and sun exposure. So in the olden days, a lot of the time, what we were doing, breastfeeding rates were higher, and what we were having was more or less like physiological jaundice. Physiological jaundice is said that it will resolve on its own, like we said, whether you expose it to sunlight or not to sunlight. The sunlight has some amount of UV light, but mixed with all other things. There have been studies where in other African countries where they have created tents and have sought to sieve the sunlight so that you can focus the blue light from the sunlight onto the baby, but not directly exposing the baby to the lights. And like I also explained during the phototherapy technique, you need the baby to be 30 to 45 centimeters away from the light. So I'm wondering if you are exposing this baby, see how high the sky is and where our homes are, whether it will be good therapy enough. So it still remains a myth. We don't encourage mothers to do the sunlight exposure because of two things. One, it delays them in coming to the hospital. And two, it may not be physiological jaundice that the mother may be dealing with. Physiological jaundice, exposure or non-exposure to sunlight will resolve, but what if it's not physiological jaundice? So we tend to demystify and say that they should seek early care, come to the hospital, let's examine and decide whether you should go ahead and do exclusive breastfeeding or we'll prescribe another modality for you. But the sunlight therapy still doesn't work. The GSSPD is an enzyme defect. So at the end of the day, if the mother has GSSPD deficiency and has a male child, that child may likely have the GSS because of the mode of inheritance. It's excellent. So when you have a mother who has a female child, yes, maybe you are not looking at GSSPD deficiency, but if it's a male child, then you would have it at the back of their minds that they may have the deficiency. And once they have the deficiency, there are some food, drugs, and things they cannot metabolize, and camphor is one of them. So that's where the camphor use comes from, herbal preparations, some special foods, some special antibiotics. So that is why they are not able to metabolize. It increases the risk of hemolysis. The red cell breaks, and once there's hemolysis, it will increase the risk of bilirubin, and then your unconjugated will be higher. And that, if not bound, can go into the brain and give you severe consequences of the jaundice. I hope I have answered your question.
Great. Any other comment, question? Kindly electronically put up your hand and then I'll ask you to unmute yourself. There's no hand up yet. So if you have a question, comment, please put up your hand. Teresa, great. Please unmute yourself and go ahead with your contribution.
Okay, good afternoon, Doc.
Good afternoon.
Please, I have two questions to ask. Yeah,
Okay.
please, I have two questions. One specifically about the general section unit. You said if the child is macrosomic after delivery, you should do the groupings and cross matching test for the child. I want to find out, is it only the macrosomic unit or it applies to all units that go through the cesarean section? And the second question is on the exchange blood transfusion. When that thing is the procedure, do we consider the weight of the child in terms of low, like the small for gestational age, extremely preterm, and all those things? Do we have to consider all those things before the exchange of blood transfusion is being commenced? Thank you.
Okay, so doing the blood group of the baby has to do with the case study we looked at. So the mother had a big baby, had a cesarean section, and then the mother was O negative. So for the O negative mothers, if the baby are picking the blood group of their fathers, then you would have a rhesus incompatibility. And from experience, that gives a very high level of jaundice. So if you are the rural area and you want to eliminate risk factors and you have a baby that is, or a mother that is a negative blood group and has delivered the baby, you don't know the father's blood group. Even if you want to take a decision to give anti-D, it's the same procedure you go through. So you will do the blood group of the baby. And if the baby is a negative blood group, then there is no risk of the baby doesn't have an increased risk of neonatal jaundice. But if the baby has a positive blood group, then that baby is at a higher risk of neonatal jaundice, considering that the mother may have been diabetic, which will make them polycythemic, and then have delivered via cesarean section, and so may not be feeding as we expect and would have infrequent stools. All these ones will compound the risk factors and make that baby jaundiced. So the checking the blood group has to do with the rhesus negative and not whether it's CS or not. Teresa, I hope I answer your question. Then with the exchange blood transfusion. So as we know in pediatrics, everything is based on your weight, whether we are calculating fluid, blood, medications. So if you have to perform an exchange transfusion, the volume of blood you are using is dependent on your patient's weight. And so whether you are term, preterm, big or small, the volume is calculated based on the child's weight. So yes, the weight doesn't matter. The only other things we consider is whether the child already has signs of connectors. So if that child is having seizures, is in respiratory distress, cardiopulmonary instability, then because the procedure itself can cause cardiac arrest, you may not want to do an exchange transfusion with a child that is actively seizuring or having, but aside that, if the child qualifies for the exchange blood transfusion, is it dependent on the weight? The volume of blood is calculated with the weight.
Great, thank you. Next. Can I find sun is up? Yeah, Lawrence, please unmute yourself and ask your question. Or make your.
Okay, Madam, thank you for that wonderful presentation.
Thank you.
I have one question and one contribution. So the question is, at what age can we check the GC-PD of a baby? Then my second question and my second contribution is about the barometer that my friend Francis mentioned. In fact, I'm speaking from Zebula Hospital. We were fortunate that one NGO donated one to us, and it's really, really helping us. So when a baby comes, you don't need to immediately, you use it to get the level of the bilirubin of the baby. Then we have an app. Then you put the figures inside. Then the app will tell you what you do for the baby, and it's really, really helping us. And I think if the rural areas, most of our these hospitals can get such machine, it will help to reduce the neonatal mortality. Thank you very much.
Okay, thank you. So when to check the baby's G6PD? If you give birth to a baby day one, you can check the G6PD. There are false positive, false negative results. So if your baby is jaundiced, then the baby has already started, the red cells have already started breaking down. And once red cells start breaking down, new cells are formed. And these new cells supposedly have a higher higher concentration of the G6PD enzyme. So your baby can be deficient, but because they are jaundiced and the body is trying to produce new cells, you may do that G6PD status for that baby, and the status may be normal. Not because the baby's status is indeed normal, but because the baby has jaundice and is hemolyzing. So the body is trying to create new cells, and these immature red blood cells has a higher levels of the G6PD concentration. So in a circumstance where the baby is jaundiced and you want to find out the true G6PD states, then there are two things you do. You can wait for the jaundice to resolve, wait for 3 months, which is 120 days. All the red cells would have matured and the concentration of the G6PD would have come down, and you will know what the true G6PD concentration is for that baby. So once a baby is hemolyzing, it doesn't make economical sense to check the G6PD status at that time, because based on pathophysiology, it can be normal, but that may be false. Okay, so you can wait for 3 months and then you repeat the G6PD test. But if the baby is not jaundiced, then you can do the G6PD test any day, anytime. So thank you for your contribution.
Great. Hayford, please go ahead and unmute yourself.
Okay. Good evening and thanks for the opportunity. I just joined, but I've learned a lot. There's some clarification I need. In instances where there are resource constraints, we are unable to check the bilirubin level. At what point during the phototherapy will one decide to discontinue the therapy? Thank you.
Okay. So it means that if you don't have the capabilities to do a serum bilirubin, then you are going to rely heavily on your clinical symptoms. So what I would have done with that, then you would have used your Kramer's rule to determine whether you are in stage 3, stage 4, stage 5. And based on that, you can use that same principle with subsequent examinations to decide when to stop the phototherapy. So when it gets better, when your clinical presentation gets better, then you can stop the phototherapy. The other thing you also need to consider is whether the baby is term or preterm, and at what time the blood-brain barrier forms. So in term babies, it's stipulated that the blood-brain barrier forms around 10 to 14 days. And so once the barrier forms, no level of toxic or unconjugated bilirubin can cross the blood-brain barrier again. Then a filter has happened. So at that point, even if the levels of bilirubin are very high, it cannot cross the brain. And for the preterms, we are looking at 14 to 21 days. So if you are in a setting where you are not sure whether to stop or not to stop, then you can use these as guidelines. Has the clinical picture improved, or has the blood-brain barrier formed? If it has formed, then you can stop your phototherapy, because your aim of doing phototherapy is to reduce the hyperbilirubinemia so that it doesn't cross into the brain. But you can still go ahead and investigate and find out why the baby is jaundiced. But the aim of the phototherapy is to reduce the severity of the hyperbilirubinemia so that it doesn't cross into the blood-brain barrier. But once that blood-brain barrier has formed, it means that it filters the bilirubin, and so it wouldn't allow the bilirubin to cross, and so you wouldn't have the tendency of the neurotoxicity. So those are the things you can use to determine when to stop phototherapy. Because if you have a bilirubinometer, once you start phototherapy, it doesn't give you consistent value. It has been shown by studies not to reflect the levels of the jaundice again. So you have to rely on clinical signs and symptoms. Hayford, I hope I answered your question.
Yes, I'm fine. It's something we've been battling at our end. There are several times one will have to decide either the jaundice have cleared or not. And so if I decide that I have seen something of jaundice, then I will still have to continue. But someone will come and say, oh, I have not seen any more jaundice, and so this baby is fine and can go home. and at times this gives some of them complications, and they have to come back. And so I
you
need
can
to
go
know,
back to the diagram I showed, the Kramer's rule. When you have rule 1, mild jaundice, you can let them go home. Tinge of jaundice, aggressively breastfeed. Give them a short review, 2-3 days. Come back, let me observe and see. But if the baby is at rule 3, rule 4, rule 5, that one all of us can see. So that's pretty obvious. But when to stop it? If you are debating whether it's 1 or 2, it's still in mild. So if you have established breastfeeding, you can let them go home, aggressively breastfeed, and come back on a shorter review for you to re-examine, so that you don't keep them in the hospital for a longer time, because that also has its own risk.
Okay. Thank you.
All right.
Great. Samsung SM, please introduce yourself and ask or make your contribution. Yeah, someone has put up their hand, but there's no name. It's Samsung SM. Please go ahead, introduce yourself and make your contribution.
Okay, thank you very much for this lecture. We've learned a lot, actually. I don't know whether this is a contribution, but there are instances where parents, when they realize that their kids have turned yellowish, instead of them bringing them to the hospital, they rather get this blue light in their room. So with this, I'm thinking that education has to go like fast. We need to educate these mothers and parents that it is not done. When you kind of like notice that you have to bring the child for assessment. This is what I want to add up.
Yes, thank you. Thank you very much. So yes, these are things that have come up. So as healthcare workers, when people come to our facility, they observe what we do, and we probably may need to explain to them why we are doing that. So the mother comes to the hospital and sees that when the baby is yellow, we put them under light. So if my baby is yellow, let me change my room lights into blue, and I will solve the problem. But they haven't taken notice of what we have done, whether we have undressed the baby, we've covered their eyes. They don't know how, they haven't taken notice of how close the light is to the baby. And so these are things that we need to intensify our education. It's the same with the formula feeds these days. They come to the hospital, they see us give some babies formula, and they are like, oh, when we came to the hospital, the nurses, they were giving formula. So we can also give formula. So a lot of the time, they pick cues from what we do. And so we either have to explain to them why we are doing the things, or we have to educate them extensively for them to understand that the cases are on one-on-one basis. And so they would have to take it like that and report early. So thank you very much for your contribution.
Excellent. Stephen, I think this is the last one we'll pick because we've gone way beyond the hour mark. So Stephen Abani, please unmute yourself and go ahead with your contribution.
Okay, thank you very much. Legendary. I thank the doctor for that wonderful presentation. Actually, my network is not too good for me here. That is why I'm off and on. But I want to find out, it's a follow-up question on what Lawrence asked, and then the answer she gave about at what age should we do the G6PD tests? And she said 3 months. So I want to know if it is a preterm baby, let's say 30 weeks or 28 weeks, are we working with the corrected gestational age, or we should just count, the 3 months from the day the baby is born, then we do the test. Thank you very much.
Okay, thank you. So when it comes to preterm babies, the only time we deal with corrected gestational age is when we are trying to correct for their developmental milestones. But once they are born, everything else is based on their date of birth. So like if you've noticed, they will go ahead with the normal immunization schedule. We are not saying that we wait for them to be 10 before we give them polio. And so it's the same thing for all other things you would want to do, all other investigations you want to do. You would use their date of birth. However, when it comes to their developments, then you would have to correct their gestational age. Because if they are very preterm, they may be lagging behind like 2 or 3 months. And that can make a difference, because if you look at when you are 6 months, you are supposed to be sitting. And when you are 9 months, you are supposed to be crawling. By a 9-month-old preterm born at 30 weeks will still be sitting at 9 months. And so that is where the corrected gestational age comes in when they leave the hospital. But once they leave the hospital, the only relevance of the corrected gestational age is in explaining their developmental milestones. Otherwise, every other thing is based on their date of birth like we do for all others. So yes, when they are 3 months, you would check their G6PD if they were jaundiced at birth.
Great. So I said that was the last one. Unfortunately, somebody put up their hand, so I allow you to go ahead. Portia, please be snappy and then we can close.
Hello, thank you. Good evening, and thank you, Dr. Masoda, for the presentation. I wanted to ask a follow-up question on the GCPD. You mentioned that as early as a day and to 120 days, we can check the status. So I wanted to ask those of us as the CWC, can we offer to test for the healthy babies at the CWC if they can afford to do it? The GCPD and the sickling status.
Okay. Portia, you have brought another dimension to it. So yes, if if your baby is well and you don't have any reason to take any blood sample, I personally think it's unfair, Portia, to go and prick the baby to say, I'm checking for your G6PD and then your sickling status. The sickling status is typically not checked at birth because sickling and HB electrophoresis won't give you an accurate figure unless you are doing a HPLC at birth. So how we check for sickling at for the newborns are a bit different from what we do typically in the labs. If for a reason you are taking a blood sample, the baby is not sick, but you are taking for a blood sample for another reason, which you need to, you can add the G6PD and know the baby's status. But for sickling, we would check it when the babies are at 6 months because of the presence of fetal hemoglobin. So there's fetal hemoglobin that is there from 0 to 6 months. It decreases, is highest when they are born and decreases as they go to 6 months. So we want to know what their final HB electrophoresis will be at 6 months. So at 6 months, Well Clinic would do a full blood count. We would do a G6PD anyway because they are coming to start complementary feeding and we want to be able to tell whether you can give them soya bean. They can take all the other things. Yes, so at 6 months, because you are starting complementary feeding, you are supposed to do their full count. You are supposed to do their G6PD. And so at that time, if you want to do their blood group or their HB electrophoresis, you can take the opportunity to take the sample. But I personally don't think that the babies are well, there's nothing wrong with them, but just because you want to know their GCPD status, you will go and prick them. I'm not of that view because I still believe that it's painful. But if for any reason you are taking a blood sample, you can do their blood group, you can do their G6PD, and then wait till they are 6 months and you do their sickling status. Portia, I hope I answered your question.
All right. So thank you so much. I guess that was well answered as well. I want to say a big thank you to you, Dr. Matilda, for this legendary job. Really, you taught us a lot. Lots of people are in the comment section are full of praises for the very educative webinar that we presented today. We are grateful to you, Dr. Matilda. most of the comments in there are just saying how great the presentation was, and they are thanking you for the great presentation. We are grateful as well that you've been able to enlighten all of us on neonatal jaundice, especially on in this month of May, which is used for awareness creation about that. We are grateful to you. To our
Thank you very
participants, thank you
much.
so much.
Yeah, thank you very much. I'm honored to do the presentation.
You are a legend. Thank you so much, our participants, for joining us for this week's presentation. Kindly look up on our social media handles, Ghana Medical Help, Facebook, Ghana Medical Help on LinkedIn as well for adverts of our next presentation. And then this recording of the webinar on neonatal jaundice will be put on our YouTube channel, same name, Ghana Medical Help. So make a date with us another time for another interesting presentation. Have a great day and God bless all of us. God bless you, Dr. Matilda. Bye-bye.
Thank you. Bye.